first of all, thank you everybody for coming. We really appreciate waking up this early.
So, is it possible to show the presentation here also?
No.
Okay,
not.
let me
Okay.
know.
You have two screens, one on each
Well,
side.
look, we can see
wow.
it there.
Okay.
So we're going to talk. We're going to try to give you a little bit of what we do for arrhythmias in our department. Just a couple of points. So I think this is, at least this is the way I feel sometimes when I have an arrhythmic patient in my unit, especially at nighttime when my cardiologist is at home, or I have a young cardiologist up on the ward. So we're going to try to just give you a classification of what arrhythmias are in pediatrics, and we're going to present some clinical cases, and we're going to divide them into atrial and ventricular tachyarrhythmias and bradyarrhythmias. So this is how, in my mind, I classify arrhythmias. So tachy and brady. So the tachy, what is important to underline is that you have to distinguish them between narrow and wide QRS complex. Now that's easy to say. Sometimes it's really difficult on your EKG, but it really makes a difference because they have different mechanisms and different treatments. So, and the silence bradycardias and the heart blocks are scarier. But anyway, I guess it just depends on how you're going to treat these patients, and just knowledge. It's knowledge on how to treat. So when the heart beats too fast, let's start with the tachyarrhythmias. So we can define tachycardia as a sequence of 3 or more beats at a rate that is more than 20% of the sinus rate at the onset of the arrhythmia. So of course it depends on age. So your neonate may already start with 130, and so then you're going to be going to really high rates. And it's important to understand if it's sustained or not sustained. Sustained, it doesn't go away by itself. You have to intervene. Not sustained, it will hopefully stop at some point. So it can be supraventricular if it originates from the atria and the AV junction, and ventricular if it goes below. This is a paper that our cardiology team, we have a very strong cardiology arrhythmia team. So they actually, and this is, these are their definitions. So let's start with sinus tachycardia. Now it's not an arrhythmia by itself. It's a fast regular rhythm with a P wave that is before each QRS complex. We all know that. The RR and PR intervals are equal. The heart rate is between 160 and 200, and it's a narrow QRS. Now, the important thing is sinus tachycardia is to treat the cause, because 90% of the time you will be able to get rid of it just by treating the hypoxemia or the low hemoglobin or giving fluids. In our cardiac patients, we're scared to give fluids sometimes, so we say no, we got to keep our fluid balance, whatever. So, but sometimes it's worse if we don't. So, we really have to treat the cause. So, supraventricular tachycardia, instead, it is an arrhythmia. It's an abnormally rapid heart rhythm which originates above the ventricles and the AV junction. But most of the time it's a narrow QRS complex. Now, when I study these supraventricular tachycardias, I was getting all mixed up with the terminology, and sometimes, someone speaks to you and says, you read in your book, it's ectopic tachycardia, it's whatever. It's always supraventricular tachycardia in your mind, at least in my mind. So that's how I deal with it. And so, the signs, the clinical symptoms are going to vary to age. I mean, we're in the intensive care, so our kids probably are going to be intubated, sedated. We're not going to be seeing them irritable, poor feeding, even though sometimes, our patients, they are awake in the intensive care unit, and they are, just floppy. So supraventricular tachycardia is paroxysmal. It has an abrupt onset, and like I said, and it also terminates quickly. Most of the episodes take place at rest, and like I said before, the heart rates depend on the age. It's just to keep in mind, it's fast, it's narrow, there are no P waves. you may be able to identify a retrograde P wave. And this is important. You can see sometimes ST depressions or AVR elevations. I'll show you an example of that. And if you see a wide QRS, it doesn't mean that it's not a supraventricular tachycardia. It means that there's an accessory pathway. So, like I said before, sometimes when you're reading, they start throwing different names. These are all synonyms of supraventricular tachycardia, more or less. These are the mechanisms responsible. There are reentry, most are reentry mechanisms. We can have pre-excitation and we can have triggered activity. So atrioventricular nodal, this is what happens basically, and we remember these things from our medical studies. The sinus node goes, the impulse goes through the slow, and then the other impulse will go to the fast route. They meet at the AV node, and then they cancel each other and they go down. If you have an arrhythmia, the impulse will travel, and then it goes through the slow, and then maybe the fast, it finds a refractory. There's the pointer here, isn't there? Or maybe this. Here you can see this is a refractory. It will find a refractory period, so it can't go. So it's blocked here. It will take this route here, and then by this time the fast. Will no longer be refractory, and so you have that circular mechanism which is responsible for your reentry tachycardia. So here is a typical EKG of a reentry tachycardia. I can't see any P waves. So just keep this in mind. Another mechanism, which is just important to keep in mind, is that we can have it orthodromic, which it's when you're here. It starts here, the impulse, it will take the regular direction, and it will form, your impulse will keep going into a circle. Now if we have antidromic, it goes in the opposite direction. And why is this important? Because this will give you a narrow complex. This will give you a wide complex, and it will look like, you may think that it's a VTAC, but it's not. So, and this is common overall it's an arrhythmia that you see in kids. It's Wolff-Parkinson-White. The diagnosis is done by EKG, and you can see short PR interval, but what's characteristic is the delta wave, which is this one here. Wait, we have another there. And how is this? This is a pre-excitation. Well, oops, sorry. Okay, so here you have your normal impulse that goes down here, and then here you have an accessory pathway, and you have another impulse that comes from your accessory pathway, and this will be responsible for your tachyarrhythmia. And this is just the same mechanism showed in a little bit of a cartoon. Again, just to show you the accessory pathway. And this is characteristic because, for example, talking about tachyarrhythmias and supraventricular, here you have your ST elevation. You might think that this could be an ischemic lesion. It's not. This is a supraventricular tachycardia. Here you have a characteristic bunny ear in the V1. And I'm going to have her do this.
And talking a little bit about the treatment of supraventricular tachycardias, we usually use American Heart Association algorithms, and of course the first thing you have to check for is hemodynamic stability or not. If you have hemodynamic stability, you can go on with vagal maneuvers. We'll see what kind of maneuvers in infants and children. And if it doesn't work, you can go with adenosine, a rapid flash, of course. You start with 0.1 milligram per kilogram in rapid bolus. You can also repeat the bolus with a higher dose, 0.2. And if you have no response, of course, our cardiologist can proceed with a transesophageal overdrive. We can proceed with cardioversion, of course. It's something we know best. On the other hand, if you have hemodynamic instability, don't waste time. You can give adenosine only if you have it already on at the patient bed. Otherwise, go on with cardioversion. Synchronized cardioversion, of course, cardioversion means it has to be synchronized. Vagal maneuvers, talking about this. In smaller infants, we can do the diving reflex. You can put eyes on the baby's face, or you can perform a Valsalva maneuver. It's easy to ask a child, a grown-up child, to, for example, to blow in a small syringe without a needle. Okay, you blow it inside and you perform a Valsalva maneuver. Carotid sinus massage actually is not so recommended. Valsalva maneuver, usually it works. And this is the pharmacological IV treatment for those SVT who are sustained, but actually the most frequent drug we use is amiodarone with a bolus of 5 milligrams per kilogram, and then we start with an infusion of 10 milligrams per kilogram for, a day for 24-48 hours, and then we go down. Synchronized cardioversion, I told you before, you have to put the synchro on because you have to make your shock message with the QRS. You don't have to give your shock somewhere in the EKG, because if the shock falls on the T wave, of course, I think that by mistake, every one of us have experienced that bad case. Of course, only in VF or ventricular fibrillation or tachycardia without pulse, we are talking of cardiac arrest, and it's something else. You administer not synchronized shock with another dose, of course, of energy. Junctional ectopic tachycardia is I'd like to show you this kind of tachycardia. This is the most common after a cardiac surgery. It is life-threatening. It has an automatic focus firing. It is fast. It goes over 170 up to 260. Narrow QRS, AB dissociations. P wave usually are absent. You can see them. And creates hemodynamic instability and does not respond to adenosine. Adenosine actually we can interpret it also like a diagnostic drug, and we'll see when. The impulses will be conducted to the ventricle faster and more often than the atrium, so this is a VA dissociation mechanism, and it's also the diagnostic feature. And this is, for example, junctional ectopic tachycardia after a tough repair. It happens usually when the surgeon goes deep with a scalpel because of ventricular hypertrophy. And so just after tetralogy of follow repair is quite common. These are other EKG showing for no P waves. You can see also the epicardial EKG showing no P waves on B and then on D. You can see how 24 hours later P wave appears, and they are normally preceding each other QRS. How we can manage with junctional ectopic tachycardia? Well, avoid inotropes, of course. It depends on the patient. You should give less inotrope you can. Okay, less epinephrine actually with this pro-arrhythmic effect. Electrolytes optimization is the most important thing to pursue. Treat anemia, acidosis, hypoxia, sedate the patient. Why not dexmedetomidine actually? And cool it a little bit.
Yeah, just some centers are actually, they're writing their protocols with dexmedetomidine, you know, as one of the first line treatments. I mean, we use it, I don't know what you guys do, but we use it for almost all our patients, so we see much less of these. So, I mean, maybe everybody will be doing that soon. Sorry.
No, of course, yeah. Thank you. For the moment, as I told you before, amiodarone is our preferred drug. We start with the bolus, and then we make the infusion follow 10 up to 20 milligram per kilogram a day for 24-48 hours. Rapid atrial pacing could be considered after surgery, especially if you have epicardial electrodes, and sometimes in the worst refractory cases you have to consider ECMO because of hemodynamic instability. Flutter, on the other hand, is a macro-oriented tachycardia. Pediatric patient is very fast. We can go up to 2075 up to almost 600 BPM. We are talking about ventricular atrial frequency, not ventricular. What we see in ventricular frequency is a little bit different. Actually, my first flutter I saw had 290 ventricular frequency, and it was a 5-month-old infant. Neonatal atrial flutter is really rare, usually idiopathic, while on the other hand is very common in patients with congenital heart disease and also after surgery because of right atrial hypertrophy or dilation. Actually, that infant I saw had a very big right atrium. And atrial flutter responds to synchronized cardioversion. The sawtooth is the diagnostic sign, and we can see it on the top. And what I told you before, adenosine is a diagnostic drug. It's absolutely true in atrial flutter, because lowering the ventricular frequency, you can actually perfectly see the sawtooth between the QRS complexes. Cardioversion is always the same, 0.5 and up to 1 joule per kilogram. And don't forget, of course, to sedate your patients. Atrial fibrillation, it's another supraventricular tachyarrhythmia, but it's very rare in kids. Rhythm is irregular. We have no P waves like most of all of supraventricular tachycardia, but the peculiarity of atrial fibrillation is that we have a variable RR interval, and management can be drugs that slow AVM conduction, atrioventricular node conduction, and from beta blockers, also amiodarone, in the worst cases that give hemodynamic compromission. Of course, always cardioversion is our best friend. Let's talk a little bit about wide QRS tachyarrhythmias, so we have to go down to the ventricles, ventricular tachycardia and ventricular fibrillation. Ventricular tachycardia can be also with a pulse, not just a cardiac arrest rhythm, not just shockable rhythm. When you have, it is quite a threatening condition, ventricular tachycardia, and it can be actually permanent, incessant, a sustained ventricular tachycardia sometimes. How can we manage with it? Once again, hemodynamic stability or instability. If you have hemodynamic instability, don't forget to to put the synchro on. Once again, cardioversion. On the other hand, if you have hemodynamic stability, you can start antiarrhythmic drugs. You can have your sinus rhythm back, or go on with a persistent ventricular tachycardia, and so once again treat it with synchronized cardioversion. These are the drug options: propafenone, flecainide, adenosine, verapamil. These are all our cardiologists' protocols. And once again, this is another best friend of our of us in treating tachyarrhythmias. Once again, the low dose, and once again the maintenance. Of course, especially in ventricular tachycardia, we have to have to have a strict BP monitoring, blood pressure monitoring, due to the blocking alpha blocking effects. And lidocaine is also used, well, not so often actually, even if sometimes this is able to convert a ventricular tachycardia into sinus rhythm in up to 1 on 5 cases. We have a low dose again, 0.5 to 2 milligrams per kilogram, and a maintenance in continuous infusion. But be aware of the CNS, of course, side effects. That's why we don't use it actually so frequently. In long QT syndrome, we have some, it is a specific case. We have a ventricular tachycardia who has the shape of the torsade de pointe. And it is the only one that can be treated with magnesium sulfate, with IV magnesium, at the dose of 0.1 grams per kilograms and 24 on 24 hours. But we can treat it also with a boluses from 30 to 100 milligrams per kilograms, and we don't have to give amiodarone. But likely in this specific cases, we can have both a history of long QT syndrome, and it's something easier for us not to give amiodarone because we have the patient history on our side, but also because of the characteristic pattern of the tachyarrhythmia that is narrow and then wide and narrow and wide, and the torsade de pointe is quite actually peculiar. And ventricular fibrillation, tachyarrhythmia, yes, of course, but we are talking about something else because we are in the cardiac arrest algorithm. Yeah, we have to treat it with CPR, the fibrillation, and we all know how the algorithms proceed. Actually, this is a cardiac arrest algorithm we actually have to follow for these cases of ventricular, of shockable rhythms. Well, it
Okay, we're gonna tell you, this is a real case. We're gonna give you a couple of real cases. This is a kid that presented to our unit, 2 years old, 12 kilos, no real history, except then he was already in treated in another unit. So he had already had a neonatal SVT, and then fine for a little bit of time, and then he had a new episode of SVT, so he was brought to us. We did an echocardiogram, normal, no family history of heart disease. This is his EKG. You can see that it alternates, doesn't look too good.
Not at all.
And then again, EKG. Now, we did a Holter, because we know what's happening here, and basically what our cardiologist found was that he had junctional tachycardia, ventricular tachycardia, kept alternating. You can see that these are different Holters on different days. So, I mean, he was really monitored. So we did another ultrasound. We did, let's do a cardiac MRI. Maybe we don't know what's happening. We did that. Still couldn't.
It was all normal.
It was all normal.
Yeah.
So what happened before was on the cardiology ward. Then he gets worse, and he's transferred to us to the PQ. And this is what we see. We start seeing a tachycardia with QRS, not so wide, elevated heart rate. So we get scared, and we call our cardiologist, say, oh, we'll take him immediately to the cath lab. We're going to fix this now. We're going to do an ablation with radio frequency. First time. Then that was the day before, this was the 26th of October. We do the... of the accessory pathway. And next day, after the ablation, another tachycardia. So, but kid's really bad now. He's got hypotension, he's acidotic. We start inotropes because with milrinone, because we can't keep him stable. We sedate him, we intubate him, we give him magnesium. Okay, let's take him again to the cath lab. So our cardiologists take him again to the cath lab. They do a temporary pacing. We extubate him the next day because we're confident. We're saying, we're cool here. We're good. So unfortunately, new tachycardia. So again, our anesthesiologist goes there, re-intubate, hypotension. We're not going to give him adrenaline because look what happened. So we give him milrinone, we give him vasopressin to keep his blood pressure up. In the meantime, we've started all these drugs here. We've done amiodarone, we've done propranolol, we've done nadolol, we've done everything. This is our monitor. Scary. And let's see if this works now.
Yes, this was
you can
before
see
the third attempt of
ablation.
Yes, ablation.
So this is, you can see
how variable it was actually. A little bit of perhaps sinus rhythm, and then again.
And then again.
Whoa.
Okay. This is a severe case.
It's quite difficult to understand.
But you see blood pressure going down.
Okay, let's go back to the to the cath lab for the third time.
So 2 years. And this is what give them credit. They took him to the cath lab the third time, and this is what they did. They basically ablated everything.
This video, you can make it start.
Is it?
Yeah.
Oh, sorry.
Finally, at the third attempt, they succeeded in ablating the pathway, the accessory pathway, that gave both a junctional and ventricular tachycardia. And the red spots are those who they ablate.
The patient's completely fine now. He was discharged home.
It was really tricky to find the spot, actually. But finally, we had sinus rhythm.
This is third ablation attempt.
By ECMO.
Oh yes, this is important to say. We had the ECMO machine always next to the patient when, not only during the ablation attempts, but in the intensive care unit, because this is a case where you might need to use ECMO.
When the heart is too slow. Okay, let's talk about bradyarrhythmias now. We have sinus bradycardia and sinus node dysfunction. They are both common after pediatric cardiac surgery. We have a regular rhythm without P wave, with P wave before each QRS complex. Slow heart rate. We have to treat the cause once again, and we may actually require temporary pacing in AAI or VVI mode. It depends. And other bradyarrhythmias following, we can have them also following cardiac surgery, are atrioventricular heart block. It is a disorder of AV conduction, first degree block, okay, with don't worry a lot about it. We have a prolongation of PR interval. While second degree block, we know that we have Mobitz 1 and Mobitz 2, different kind of second degree block. Mobitz 1 is a prolongation of PR interval until P wave is blocked and not followed by a QRS. And the worst of the two is the Mobitz 2, of course. Intermittent and sudden block on the AV conduction. It's suddenly a P wave, is not followed by a QRS, and it could actually evolve to a third degree block where then we have a complete interruption of the AV conduction. This is, of course, the algorithm for acute management of bradycardia, always by the American Heart Association. And first of all, we note that we should actually ventilate the patient in bradycardia, because very often it depends on the hypoxia. For example, in patients who are still sedated after cardiac surgery, for example, if we have extubated a patient, we have first of all we have to ventilate it. But if it doesn't work, of course we can proceed with atropine or epinephrine boluses. Atropine it's useful only when you have a vagal origin of the bradycardia. On the other hand, if not, you can give an epinephrine bolus. But for complete heart block, we have to underline how the only definitive therapy is a surgical pacemaker implantation. It happened to us, probably a couple of 3 months ago, a young boy undergoing, I don't know which number of surgery it was, and had a history of heart block, not advanced heart block in the previous surgeries, but it happened that after phase of, it was a Mobitz 1 block in the early postoperative period, then he recovered with his sinus rhythm, but once he was in the ward, he developed suddenly a complete heart block. So we have to go to the cath lab at 4 a.m. in the morning because of this complete heart block. We have to give him a pacemaker implantation in a hurry. This is another clinical case, yes?
This is, I would say, what I would call a typical case. I mean, this happens a lot of the times, luckily. This is Emily, large VSD. She was corrected, no complications, except coming out of the operating room with a complete heart block, 2-1, 3-1. Of course, our surgeons, don't worry about it, temporary pacing. So then the fourth post-operative day, the pacemaker wasn't working, our temporary pacemaker wasn't working, but luckily she had an underlying ventricular heart rate of 75 with no hemodynamic compromise. So this is her EKG. You can see, and well, since it wasn't working, we disconnected the temporary pacemaker. This is what we always do. I don't know if you guys do this too, but we always give some cortisone, 0.1 milligram per kilo. This is something our cardiologists stress quite a lot. So we just waited. We waited for a bit of time, and we're on day 4 now. This is day 5, day 6, still heart block. You don't see the blood pressure, but she was hemodynamically stable, junctional rhythm. This is day 7, complete normal. I mean, we were already taking her to the, to the surgery, put pacemaker, and our cardiologist kept telling us wait, and we did. We waited, and so she avoided a pacemaker. So just a couple of messages. I mean, arrhythmias are common in the PICU. Anybody that works in the CICU knows, has seen them. They can be tricky. keep in mind the algorithms, the American Heart Association algorithms, because they are clear and they really help. I mean, they help me. I mean, and I guess, and when you don't know what to do, call your arrhythmia team if you have one. So that's it. These are our emails, so we're always available. What are your experiences with arrhythmias in general? Do you guys have a team, arrhythmia
Dedicated
team? Yeah,
cardiologist,
dedicated. And you?
No, we treat many of the arrhythmias ourselves.
Yeah.
With
Okay.
a cardiologist in the background, if we go beyond the normal.
Yeah.
So if we start using Ivabradine,
Okay.
Oh yeah,
which is a bit strange.
Yeah.
It should work on the sinus mode, but in gentle, it really seems to work.
Yeah, I read that that's one of the first line therapies. They haven't, our cardiologists are very keen on it, but we've only used it once, I think.
Yeah.
It's a hassle to get it.
Oh no,
For our pharmacy,
really?
they know it by now after 3-4 weeks.
Yeah. Is it expensive? I have no idea.
I don't care.
Yeah.
Don't care about the money, but they find the right way to deliver to a child into.
Okay.
Oral, so you need to have.
You have it, an NG too, but yes, yeah.
Child
Okay.
needs to be able to feed. Usually that's it.
And it works?
Yeah.
We had a kid come off ECMO with a congenital jet on Ivabradine alone.
Really?
Okay.
Myocardium responded, got better.
Okay, because in fact, like I said, we've used it only in one case, and it ended up being a little bit controversial. Oh, it's not the first line therapy, so that's just, the political things behind things. So, okay.
Thank you.